Good afternoon, everybody. I hope you are enjoying lunch. I hope you have been enjoying the last couple of days. For some of us, it's been 4 days. It's a long time to be sitting around talking about Medicaid, but what else are we going to talk about in this world? What else matters? So I am pleased to be able to introduce the next and final panel for the NAMD 8th Annual Fall Conference. I always hate to say something like leaving the best for last, because then someone who spoke earlier always comes to me and says, what am I, chopped liver? But I really do think this is saving the best for last. This is the theme of the panel we're about to get into. It's actually something we did last year, and it was consistently the highest rated session of the entire conference last year. And so for us, it was a no-brainer to do this again. It was clearly the type of thing that's going to keep the majority of a lot of very busy people in their seats to the very tail end of a conference. And so I'm glad you're all sticking around for this. But this is going to be essentially what just happened with the midterms. What does it mean for healthcare? What does it mean for Medicaid at the state, the federal level? And what else do you want to talk about? Featuring the best healthcare journalists in the country. All I'm going to do is introduce the moderator, and he's going to take it from here. One of the other things that I've learned in my career in doing this type of thing is you learn in show business, you never follow animals or children. I've learned that you never follow Rodney Whitlock because he is the funniest, smartest person you will know, and you will always look bad if you come up after him. So that's why we've saved him and this panel for last. But Rodney is a longtime titan of the Medicaid world in the U.S. House, in the U.S. Senate, and now in sort of his gadfly days in the private sector. But I couldn't think of anybody better to kind of lead this session in a lively and a provocative way with some of the most important journalists and media people that we have in this country, in this city, talking about healthcare and Medicaid. So with that, I'm going to turn it over to Rodney to introduce the rest of the panel and say, enjoy your lunch, and I hope you have as much fun with this panel as I do. So Rodney, take it away.
Thank you. So thank you all for joining us. I know that we're the last thing, so we best deliver here. On today's episode of the What the Health podcast, the people who are actually on it are going to get tortured by somebody who's never on it. So rather than go through a long introduction for each one of you, let's do it this way. All right? Talk about where you are now, a little bit about how you got to where you are. And for a room like this, who doesn't really understand what it means to be a reporter, what you do every day, give them the opportunity to understand what it's like to be you. And we'll start here, of course, with Stephanie Armour.
Hi, I'm Stephanie Armour. I am the health policy reporter at the Wall Street Journal. I cover kind of healthcare policy, and that means like anything and everything, whether it's Ebola to what's happening at CMS to what's happening on the Hill. The beat itself has expanded and expanded, it seems, as more and more is going on. I am from Minnesota, Minnesota nice. And I always knew I wanted to be a reporter. I think I started my first newspaper in 4th grade that I sold door to door on a little red wagon, and it was called the Daily Bugle because I couldn't spell bugle. And that is not my password on anything today. And I went from Minnesota to the Des Moines Register, and before that a small little paper called the Daily Tribune, where you had to write 2 stories a day by 8:30 a.m. in the morning, and I qualified for free cheese because I didn't make much money. So I definitely went into this job not for money, but really because I feel like you can make a difference. It is, to me, such a humbling and important job, especially now with healthcare such a driving issue in our country. the stuff that we write about deeply affects people, and one of the things I really get the most out of is some of the responses and emails I get from readers. Not all of them, that's for sure, but I really feel like we as reporters do an important job of educating people. There's a lot of misunderstandings out there, and that's kind of where I see our role as almost being one of the most important right now.
Okay. Paige Winfield Cunningham, and before you get underway, you had to know this was coming, right? Everybody. Happy birthday to you. Happy birthday to you. Happy birthday, Paige Cunningham. Happy birthday to you. Yeah. You knew I was going to do that, didn't you? Okay. It's Paige's birthday, and now you may proceed.
So yeah, thank you very much for that. I'm Paige Winfield Cunningham. I work for the Washington Post, and I write the Health 202 newsletter. And like Stephanie, I always knew I wanted to be a journalist. I love just like, I guess the qualities that it takes to be a journalist, which is being curious, being inquisitive, trying to find out the truth without a particular perspective. And so anyway, I grew up in St. Louis. My first job was at the Naperville Sun in the Chicago suburbs, where I covered county government, wrote about all kinds of crazy things like, the family of ducks that built its nest outside the local furniture store, and really important journalism like that. And came out to DC wanting to cover Congress, have sort of done the round of DC publications. I started out at the Washington Times, did a stint at Politico, went to the Washington Examiner, and then ended up at the Post almost 2 years ago to launch the Health 202. Never had any idea that I would fall into healthcare policy, had absolutely no interest in healthcare. But when I worked for the Washington Times in 2011, my editor there covered everything except he hated health policy. And of course, that was the time that the Affordable Care Act was starting to be implemented under the Obama administration, so he told me that was my job to cover the implementation. And so that was a really great way to just jump right in and learn all about all corners of the health policy world, is just by covering the rollout of the law, and then of course all of the subsequent political battles over it. I never would have guessed that we would have been writing about all the politics around it, 8 years out. But it's been a really, really fun ride. And I've really grown to love healthcare policy, I have to say. So really glad to be here today.
Kimberly Leonard.
Hi, I'm Kimberly Leonard. I'm also a healthcare reporter with the Washington Examiner. I've been there about a year and a half. Prior to that, I was with U.S. News and World Report. When I graduated college, I really wanted to be a reporter. I really wanted to report on healthcare policy. I've always thought that it's so fascinating to watch the way that communities provide or don't provide infrastructure for people, and how much that makes their citizens healthy and productive. And so for me, being able to report on this topic has really been something that's kind of a dream come true for me. And I am on the Hill a lot. When you see the photographs of Senator Susan Collins standing in the middle of a huge crowd of reporters, I'm somewhere in there, probably underneath. We spend a lot of time going to individual communities. I've reported on the opioid crisis quite a bit, whether from treatment centers or from different parts of the country that are really struggling. And we cover everything from what a state is doing with its 1332 waiver to what's ahead for Medicare for all. We pretty much run the gamut, and we also publish the daily on healthcare newsletter at the Washington Examiner. So that's pretty much my whole thing.
Should I use the word legend? Nah, let's just go with Julie Rovner.
I am Julie Rovner. I am Chief Washington Correspondent at Kaiser Health News. We're a national nonprofit news service, not affiliated with Kaiser Permanente. I am also, for purposes of this conversation, the host of the What the Health podcast, which is an all-woman podcast that does basically the health policy news of the week every week. And if you don't subscribe, please do. And this is basically half of our panel. So we have 10 reporters, and they sort of cycle in and out every week. I keep track of the news on the health beat, and this is my 32nd year of doing it. I actually met Rodney when he was working in the House in, what was that, the mid-1990s?
Yes, ma'am.
Yeah. So, and I actually was born at GW Hospital. It's about 8 blocks behind us. Grew up on the mean streets of Bethesda, which were not really that mean. went to the University of Michigan, worked on the Michigan Daily, and there was no such thing as health policy when I was first graduating college. But I went to Congressional Quarterly in 1986, and they had the health beat open and the commerce beat open, and they decided that I should do the health beat, and I've been doing it ever since.
Margot Sanger-Katz.
Hey, I'm Margot Sanger-Katz. I work at the New York Times, where I write about health policy for a section of the paper called The Upshot, which is kind of a fun, more digital part of the paper where I get to write for a lot of different sections. And I feel like I have come to journalism late compared to this crowd, because I went to college actually thinking that I wanted to be a scientist. And then I got into the lab and realized that none of my experiments worked and I was terrible at science. And that perhaps I should write about science. And so the idea of being a health journalist was sort of a way of continuing to engage in science and scientific discovery, and then along the way it turned out that actually I was much more interested in sort of the politics, policy, and economics of healthcare than I was about the basic science, although I'm interested in that too. So I think the most important thing to know about my career is that I spent 5 years as a newspaper reporter in New Hampshire at the Concord Monitor, which is a terrific small paper, but I think even though now almost everything that I write about is sort of national policy, it really did inform my perspective that so much of what happens here in Washington actually plays out on the ground, closer to people in states and in municipalities, and I try to keep that in mind as I go about my reporting.
All right, so we'll jump right into some of the fun stuff here. A group of us did this last year, and we were just getting over the shakes from repeal and replace. We've just had an election. The election produced an outcome. Are we done with repeal and replace? Stephanie, you can go first if you like.
Well, I think Republicans have basically driven a stake through repeal and replace at this point. Will it potentially bubble up at some point in the future, way down the line? Sure, I think some Republicans, especially in the Senate, would still very much like to repeal the ACA, but I think that the reality has hit home pretty strong after the elections, because I think that many saw it as a referendum on the repeal and replace effort. It sort of, in many ways, backfired for Republicans, because, in fact, during repeal, the Affordable Care Act became more popular than it had been before. So I do know that there are some groups, Heritage and others, that would still very much like to see it happen, but I think that its odds at this point are really very, very slim.
Anyone else want in on that one? Julie,
Yes,
yeah,
I think we're at, actually, we've replaced repeal and replace with repeal by regulation. I think Congress isn't going to be able to do anything with the divided Congress and obviously a House that's quite in favor of the Affordable Care Act, but the administration still can, and I imagine they will, and a lot of this is going to play out in court. They're going to put out regulations. Democrats are going to sue and say that wasn't really what was intended by the law, and we're going to let the judiciary, that, by the way, the Republican Senate can continue now to stock, make those decisions.
And I would add one of the biggest reasons that you saw the Senate healthcare bill or effort kind of go down is, of course, all the disputes around what to do with Medicaid and how to treat that. And of course, now after last week's elections, we see 3 more states expanding, potentially 2 more, to where we could have almost 40 states with Medicaid expansion, I think. So, you know, when you in terms of like the number of people that will be covered by Medicaid, it's just growing, which makes it politically even harder.
And there's, of course, this huge functional obstacle, which is the Democrats now are going to control the House. So, you know, even if there was an appetite for repeal and replace among Republicans, which I think, you know, as Stephanie notes, is like maybe waning, or at least is less uniform than it once was, they just don't have the power to do it. So, and I think it will be interesting to see if they run on it in 2020, but my guess, I'm sure we'll get there, but my guess is that the ground is sort of shifting, and the horizon for what we're going to be fighting about in healthcare policy is probably going to be a little different.
And let's not forget there's this big Texas v. Azar case that could really, you know, shift the conversation and either motivate Congress to maybe work together on some sort of a solution or not. And even so, it will take a few years before we know, you know, whether it makes its way up to the Supreme Court. I mean, we could get a decision on it any day, maybe right now.
Any minute.
Maybe now. We're all waiting.
Somebody's on Twitter, right? We're watching. Wait, we are the Twitter people. You know, nobody's on Twitter.
Yeah,
I know,
we're
so-
Twitter people.
I mean, no, literally, my whole Twitter feed is on stage. Sort of pulling from where, though, you went, because I think this is an interesting thread to run a little bit. For a room like this, it's worth talking about. What actually is the status of the ACA today? I mean, think about of where it has come since 2010, its passage, its implementation from day one, the flipping on of the switch. Hey, that healthcare.gov thing didn't work right as we started, but where we are today. So if you're looking at the ACA, how's it working?
So I feel like I make this mistake after every election. I say the same thing and I'm always wrong. And the thing that I say is, the ACA, this was the last chance to repeal the ACA, right? Like I remember in 2012 saying like, this is the last chance to repeal the ACA, you know, before its main provisions go into effect, and after 2014, like, you know. So, but I do think that over time, the Affordable Care Act stops being this sort of like other thing, this boogeyman that's over here to the side that you can, even just the idea, you know, it used to be we're just gonna repeal it, we're gonna just turn back the clock to 2009, and then it sort of became repeal and replace, and now I don't know exactly where we are, but over time, I think the Affordable Care Act has just become more and more kind of melded into our healthcare system. It's not this discrete, separate thing. It's all of these things, these sort of tentacles that are everywhere. And so I think it gets harder to actually even evaluate how it's doing. Like I noticed the Congressional Budget Office a few years ago, they stopped doing separate scoring for the Affordable Care Act provisions as related to everything else. So I think
they couldn't.
They couldn't. I mean, they just couldn't disentangle it. It's a huge, major reform of Medicare. It's this big expansion of Medicaid and everything else. So I think when people talk about the Affordable Care Act now, I think they're talking mostly about the Medicaid expansion, which you guys obviously know a lot about, and about the individual market reforms. I think it's sort of starting to become a shorthand just for what's happening in the individual health insurance markets, and how that's going is a little bit complicated.
But I think that while that's absolutely true, that I mean, the health system and the Affordable Care Act are increasingly one, the way the health system is working, and particularly the way the Medicaid expansion and the individual market changes are working, because of the changes that have been made, partly by the courts, partly by regulation, I feel like we're sort of retreating to where we were in 2009, which is that the kind of health care you're able to get depends not just in large part, but almost exclusively on what state you live in, which was exactly what the ACA was passed to try to alleviate. The idea was to create a federal floor so that there would be at least a basic threshold beyond which people wouldn't be able to drop. But now we have, what are we, 16, 17 states now, I guess, that have failed to expand Medicaid, and all of these ways that you can now escape from the individual market if you don't want to buy an ACA compliant plan. And that, we haven't seen it yet because they've just started, but that could really roil the individual market in those states and, once again, divide the risk pools. And then we'll be right back to where we were in 2008, which is, if you live in a state that finds, Medicaid availability and availability of coverage in the individual market for people with pre-existing conditions to be important, then you're okay. And if you're in a state whose main feeling is that we're worried about our budget and we think that people should have the freedom to buy whatever kind of coverage they want, even if it doesn't cover anything, then it might be more difficult for you. But I think we're going back to that age of sort of things are very different depending on the state.
And I think Julie's right, but I also think to add to that, I think in some ways these disparities are going to become even greater. I kind of look at the ACA as like a bowling alley, and you've got the bowling ball that's headed toward the pins, and how much of it is going to get knocked down. It's not the same ACA as originally envisioned, and I do think it's exactly what Julie said. What you're seeing now, especially because there's going to be a lot of gridlock in Congress because of the divided chambers, I think you're going to see increasingly what it comes down to is states. States are going to be the activity, by and large, where things happen. That's already playing out. You're seeing states trying to adopt parts of the ACA legislatively, kind of preemptively in case of the Texas lawsuit so that they can preserve parts of it. You see states increasingly trying to do things to make sure that they can preserve the ACA there, where you see more red states going the opposite way. You also have Medicaid expansion, which wasn't there before, so you have more people who have coverage. So in many ways, I think it's actually becoming more acute in terms of the disparity between states, and it's going to be something that really I think we will want to watch as we head toward the race toward 2020.
I would just add too, I think what my biggest criticism of the ACA, I guess, would be that it didn't address the issue of affordability for everybody. And I feel like those people are sort of the biggest losers, if you will. It is sort of gridlock, congressional gridlock, where you're probably not going to see a lot of constructive work done to improve the ACA. You still have this segment of people who are in the individual market who aren't eligible for subsidies. I was just getting my hair cut last week. I heard like a woman next to me complaining about going onto the marketplace and saying that her monthly premium was, you know, $800, $900, and she wasn't eligible for subsidies. And so I think, you know, that's a real issue going forward, but not necessarily one that we're going to see Republicans and Democrats come together to try to fix.
So I think what we established well in this back and forth here is that the ACA is producing outcomes, but as well as envisioned, certainly not as envisioned. We see differences caused by somewhat intentionally, somewhat less intentionally, that are showing up in variations in states. So we were focused on 2 R's, repeal and replace. Given the outcome of this election, a split Congress, is there potential for a third R to pop out, and that is repair? Do you see any opportunity coming forward, and Kim, I'll let you go first, for any opportunity for some sort of stabilization package, anything?
Well, they tried that last year with what is known as the Alexander Murray bill, where they were going to funnel more reinsurance into the marketplaces. That would have brought premiums down pretty significantly. But you know, as someone who was on the Hill as all that was going on and talking to different aides and kind of pulling senators aside and things like that, even though there was a small group that was working on a fix, there were others who either, you know, weren't interested in fixing the ACA or didn't want to kind of work in a bipartisan way to do it, because they wanted to, instead of fixing the ACA, perhaps take a stronger stance on the government's involvement in healthcare. You know, maybe the next thing they should look at is a public option, some of them were saying. So even though there was a small group that was sincere about getting it done, in the end, you know, it kind of fell apart because Republicans attached anti-abortion language to the bill. Essentially the Hyde Amendment, which is not part of the ACA, but the ACA is prevented from paying for abortions through an executive order that President Obama had signed. So that's been kind of like a tough spot for Republicans there. So, you know, it's almost as though if anything were to come up, how do you answer that anti-abortion question then? Because health insurance may or may not cover abortion, so it could come up again. And then obviously you have House Democrats who've said they want to do a vote on pre-existing conditions as soon as they can. And so could they repair? I could see it happening if there was something that went down with Texas v. Azar, but there's just a lot of factions within each party in terms of what the next step on healthcare should be.
Is that sort of the baseline, that all depends on Texas versus Azar? That if that were the case, I mean, Julia got a head nod that but even if it was ruled in favor of Texas, which Texas means that effectively, oh yeah, the whole thing's repealed, it still has to go through at least a year, potentially 2 years of court level changes. I mean, would that really cause action, you think?
Yeah, I think it would. I mean, the Democrats are already saying they want to do something about pre-existing conditions. Well, they don't have to do anything about pre-existing conditions. The pre-existing condition protections are currently the law. So I think what they want to do is some sort of statement that they can send over to the Senate and force the Republicans to vote for, or not, and you know, depending on sort of how they do it. But if there were to be a federal judge who would say, and most people who watch the oral arguments down in Texas suggest that this is likely, that he would say that, yeah, at very least the pre-existing condition protection should go away starting January 19th. I mean, starting January 1st, 2019. I think someone would say that, but I think that would create a sense of urgency in Congress to say, we have to make sure that whatever happens in the future with this court case, we ran on pre-existing condition protections and we meant it. So I think that actually would change the balance of what they might do, even though, as you say, it would be the very beginning of what's undoubtedly going to be a very long court battle over this.
Judge O'Connor is also, he's the Texas judge. He is also, he's ruled before things that were kind of against the ACA. So many people regard him as being sympathetic to Texas and Attorney General Ken Paxton. But I do think he is known for sort of carving out parts of decisions that are sort of difficult to appeal. I don't know how that will play out, but I know that that has some legal scholars kind of very closely watching what the potential impact could be. I do think potentially you are going to see Democrats in the House try to move something that would fix some of the ACA issues, like expanding premium tax credits to more people, changing the threshold of who is eligible, and that may kind of put Republicans up against the wall in terms of what they decide to do with that. I don't necessarily think that's going to go anywhere, but I do think Democrats are going to try and visit that. And I think one of the reasons the that the Texas decision is so important to watch is because the Judge O'Connor is kind of known for these tricky decisions.
I think part of the reason we're all nodding our heads when we're saying that so much is contingent on this Texas case is that absent some precipitating event, I think the Affordable Care Act markets have a lot of imperfections, but there is not a great bipartisan consensus on what stabilization looks like. So I think, Stephanie just outlined some things that Democrats might like to do, like expanding the availability of subsidies, and Republicans have things that they'd like to do about kind of loosening up some of the regulations of what the plans have to cover, or allowing for more state flexibility, things like that. But last year, when there was this moment of almost bipartisan compromise, there was a similar sort of emergency because the president took away this big source of funding for cost sharing reduction subsidies, and there was a fear that the markets were going to be all in tumult because of that. And so then there was this moment of coming together by the two parties about what we can do, what kind of deal can we make to fix this problem. They failed to do that. The worried about crisis did not come to pass, and so now
And
we're
then
kind
Susan
of back
Collins
to
got promised a vote that didn't happen.
so we sort of are at this status quo, which I think is not ideal, but is sustainable enough that given that there are not great ideas that everyone can agree on, I just think it's unlikely that there will be major legislation on this without something that creates a new emergency.
So we are at we've seen Republicans spend a number of years laser focused on a three-word slogan: repeal and replace. It appears that Democrats are moving in a direction of their own three-word slogan: Medicare for all. Where do you see that going in the short term, looking at this current Congress and beyond? How is this going to play? Paige, you want to jump on this one?
Yeah, so I was just looking up the polling on this actually to remind myself. It's interesting when you look at how the public views Medicare for All, because it really depends on how you phrase it and how you explain it to people. So there's more support for the idea of expanding Medicare because it's already a popular program. People generally know what it is. When you phrase it as single payer or government health plan, there's less support for it. And then when you explain to people that Medicare for All perhaps could mean more government in your life or more government control or more taxes to pay for it, support is less. So that said, it does pull, just the idea of Medicare for All, that phrase pulls relatively well. So I think Democrats did a really smart thing in this last election by, of course, many House Democrats in particular supported it, but I think where the danger lies is actually in the details. And if they actually get behind a specific plan and are forced then to explain the ramifications of that and what it would actually mean to roll out something like that, I think that's where you could get into trouble. I mean, we saw this same problem in reverse with Republicans. They won all these elections on repeal replace, but then when it actually came time to spell out what they were going to do, that was really, really difficult. And the other hard thing is, again, you saw recall when President Obama got in so much trouble during that, he was criticized for, if you like your plan, you can keep it. And there was, a certain number of people that were losing their plans. And anytime that you make people think that you're taking away coverage that they already have, that's really, really difficult to do. And of course, that's what you would have to do with Medicare for All, or at least depending on what version. That would mean a lot of people going on to a plan that they don't have right now. And so, I don't know.
Ask Bill and Hillary Clinton about that.
Yeah. My expectation is you're going to still hear Medicare for All, but I don't necessarily know that 2020 candidates are going to want to rally around a specific plan.
Just real quickly, and if you don't, can House Democrats go 2 years without bringing something to the House floor that is under the three-word banner? Kim, I'm sorry, who were you going to go
Can
through?
they go through?
Yeah.
I mean, it's interesting because most of the Democrats in the House do support it, and then a lot of high-profile candidates that were swept into office also, want to see Medicare for All be next. When I talk to individual members, they say, well, we're okay with tackling drug prices because we see that as a step toward, improving our healthcare system, maybe moving toward Medicare for All, et cetera. You have some outside groups who say, well, let's stop doing all these little Band-Aids everywhere. The healthcare system needs a fix. But what I was going to say was that, we talk a lot about public opinion and we talk a lot about where the politics lie. There are a lot of industry groups who are going to really raise hell over this. If you look at the specific plans that are out there and what Medicare rates are compared to, what the private insurance markets pay, you're looking at basically a cut in what hospitals get, what doctors get, drug companies, insurance companies, and Democrats are very comfortable talking about reining in spending on drug prices, going after evil insurance companies. But it gets a little stickier when you look at doctors and hospitals. They have much more favorability with the public. They work directly with patients. And so, whenever I talk to those groups, they are, not really comfortable with what they're hearing. They might be comfortable with, okay, if we were to match Medicare rates to the private sector, that means a lot more taxes than what we're looking at already. So, that's something that they're going to have to address too. And a lot of these outside groups will create these sort of outside patient coalitions in which they'll, run ads against the policies that are out there. I've seen that happen in every state that has introduced a single payer system. There are very strong, coalitions that are created with industry groups that really work to influence public opinion over this.
One thing I also think that I'll add to this is I think President Trump remains a bit of a wild card because he sometimes tends to go with where public opinion is. Will he come out with some kind of Medicare for all? Possible.
I wouldn't be surprised.
I also think that one of the things you're going to see is because of the gridlock on the Hill, I wonder if you're going to see, or I think you are going to see some more states moving toward New Mexico in terms of the Medicaid buy-in. No, it's not Medicare for all, but it's such a nebulous topic and people define it so many ways that may be a mini step forward. I don't know that it's actually going to happen. You obviously see many other states have looked at this and had some pulled back, but I do think you're going to see some more interest at the state level, at least in a couple of states, for Medicaid buy-in.
I'm going to offer some free advice to Democrats, which I offered to the Republicans in 2011, but they didn't take it, which is you better explain to the people that you're leading what it is that you're talking about. Because, for the Republicans, there was no replace in the repeal or replace. I mean, it was Jeff Young's joke on Twitter that he would, the Republicans would say, like in the middle of 2011, we're going to unveil our replacement bill next week, and Jeff would tweet just in time. Well, he's been tweeting just in time for 7 years now, because we've never really seen a replacement that the Republicans rally around. I think the same goes for Medicare for All, which is a great catchphrase, but it means completely different things, not just to the public, to the people who are saying it. It means completely different things. I was on C-SPAN just for a few minutes last week by phone talking about Medicaid on what had happened in the elections, and then they had sort of an hour of open calls from the pen. Since I was up, I watched, and one guy called in and he said he had lived in Germany and he was in the hospital and for 4 days and he got great care and they didn't even send him a bill, and we need a single payer plan like Germany's, to which I'm not at C-SPAN anymore lying in my bed saying, but Germany doesn't have a single payer system. So I think we have a bit of an educational effort before the Democrats start doing it.
I think there's sort of two things that are happening, and they're almost running counter to one another. So one thing is that I think that the politicians and the policy analysts and the advocates who really want single payer actually are doing their homework behind the scenes. And we've seen over the last year a proliferation of various different proposals, a number of small conferences where people are kind of hammering things out, other kinds of meetings, and I think a kind of parade of people up to the Hill to talk to some of the Democrats who are the leading advocates for this. So I do think that there is a genuine effort on the part of certain Democrats and certain policy experts to get specific, just say if we are going to pursue a single payer plan, we got to figure out what it is. We have to have consensus around what the plan looks like. We have to figure out what are the moving pieces that we're going to negotiate over if we move forward. So I think there's a serious effort. I think we're sort of a little bit beyond slogan territory in some offices now. But at the same time, I also think that the political enthusiasm for single payer has waned a bit. It was such a important part of the Bernie Sanders campaign. And I feel like after the presidential election, when there was so much concern about repeal and replace, the Democrats, I think, were kind of excited about having like a big shiny thing that they were going to do that was better than taking everything away. And I think they've just had an election where they won all over the country on a message of, we're going to protect what you already have. And it was just, for me, having covered a number of these elections, it was really, really striking and interesting to see the Democrats on offense about health care after a bunch of elections of being on defense. So repeal and replace just was really great for Republicans. They won a lot of elections on it. They rallied their voters around it, and the Democrats were sort of not sure what to say. I think in this election, it was almost completely reversed, where you had Democrats talking particularly about pre-existing conditions, but also about other kinds of consumer protections, that they were going to be a bulwark against the marauding hordes, and it seemed to work for them. And so I think that that has led to some reluctance to try to reach further, that maybe electoral success for them lies in just protecting these consumer protections that people already have and value, as opposed to trying to reinvent the system and then be on the defensive again.
So let me turn to a subject of which there is fairly clear consensus in Washington on. That is, prescription drugs cost a lot of money.
Too much.
Value statement. I'll let you make it.
I think there. I'm not making the value statement. I'm saying I think there is consensus among in Washington that they cost too much.
It's an applause line. Watch. Prescription drugs cost too much, and I'm going to do something about it. Okay. Now, note, I didn't have to say in any way, shape, or form what I do, just that I would do something about it. And so clearly, our political world has grasped the value of that statement. The administration has a very robust agenda where that is concerned. The Democrats clearly are very willing to take on the issue. We have a Democratic House, the administration in this space. Is there potential for actual policy to get done in this space in the next 2 years? So the jump ball thing stopped working all of a sudden.
Answer this question first. Who's going to be the Speaker of the House?
Oh, wait.
There's so much.
Moderator, stop asking me questions.
There's so much that's still unknown.
Yeah.
I mean, obviously, yes. I mean, we talked about this a little bit last week on the podcast. That if there is a space for legislating, it might be in prescription drugs. My guess, I think this is what I said last week, is that it would not be big, shocking stuff that the drug industry, which is still very powerful, would hate, but maybe some of the small stuff around the edges that they've been talking about, making it easier for generic companies to get copies of brand name drugs so that they can make generics. There's a lot of little stuff that they could do that I think they might possibly do, but I think it depends on what the atmosphere ends up and what happens in Texas.
Okay.
And you see the administration is actually somewhat focused on this issue too. So I think there are a number of things that can be done through kind of regulatory and executive authority. But I think all of the things that we're talking about are in the category of the marginal. So they are changes that will really matter for certain parts of the supply chain and that will have some effect on the kind of market mechanics, incentives, and maybe in what some people pay for some products. But I don't think that we have a big political consensus in this country about some big, shocking, transformation of how we pay for drugs. And a lot of the reason why drugs are so expensive in the country, if you sort of take aside these edge cases of weird stuff, weird manipulations, weird market distortions, it's just we have a system in which we have, very strong intellectual property protections for the creators of drugs. We have a for-profit, largely publicly traded drug industry that has a fiduciary duty to its shareholders to maximize shareholder return. I mean, we don't have a government that wants to say no and prevent people from being able to buy the latest and greatest treatments. And I don't think there's a lot of political appetite for that to change either. And so I think a lot of the kind of structural reasons why we tend to have much higher costs for prescription drugs in the United States are pretty baked in, and I think are tied to values that will be hard to shake up.
So I'll throw in a little more sort of following, Julie, your political challenge here. To reach some level of consensus, don't the Democrats have to move to the president's playing field and admit he might have one? Isn't that sort of part of the challenge of the politics of this?
Well, this has been my big question since election night, which is, are we going to see the kind of triangulation that we saw in the Clinton administration, where basically Clinton did a deal with the Republicans to balance the budget over the objections of the Democrats. He signed a welfare bill that the Democrats didn't like. He did all of these things with the Republicans that ended up getting him reelected, but it kind of ticked off the Democrats. So now are we going to see the reverse? The Democrats working with President Trump ticking off the rest of the Republicans. That's a little bit harder because the rest of the Republicans still control the Senate.
It was really interesting to watch the response of Democrats when HHS rolled out the Part B demonstration, because this, of course, is an idea that the Obama administration tried to advance, and Democrats were notably more enthused about it then. Of course, that was 2 weeks before the election, and they weren't really going to be giving Republicans any ground. But I think, I'll just be watching to see if there's any space there. I mean, this is a demonstration only applying to 50% of the country. Of course, it's something that Congress would have to pass to make permanent law, which would be several years into the future. But like, if Democrats aren't even willing, I guess, to concede that HHS is being unusually bold for a Republican administration and going after this,
some of them did.
A few, but I mean, like, leadership certainly didn't give much ground. I mean, maybe some of the rank and file, but so I like, if none of them are willing to acknowledge any of that, I think it'd be hard to see them willing to work with Republicans.
Just because I want to see the reaction, the Democrats are very comfortably in favor of the government having a negotiating role in determining the price of prescription drugs. If the president saw that and realized that that would be authority that he would have, and as we well know, he is the best negotiator in the history of negotiation.
So we have been told.
No, he tweeted that this morning. I'm not, making this up. So, what if he suddenly realized that? Is that within the realm of at all possible?
Well, but it's what Margot said. And we've been saying this, oh my God, since Part D passed in 2003, which is that Medicare can only negotiate for lower prices on drugs, and the CBO has said this how many times, if they can say no. You can't negotiate when you don't have the opportunity to say, if you won't give us a better price, we won't offer your drug. As Margot just said, people don't want to be told that they can't have their drug. That's a continuing problem with Medicare negotiation, which sounds so easy until you realize that it would mean that there would have to be, like on Medicaid, formularies, and that you're not allowed to have certain drugs. And that's, obviously, and I know in Medicaid there's all kinds of ways to get around it, but in general that's, and remember when they were putting together, actually you guys don't remember, when they were putting together the lists for Part D when it was first going into effect, there was a huge fight about you have to not just have one drug in every therapeutic category, you have to have 2 or 3 or 4 drugs in every therapeutic category that would be preferred. They did it in such a way that they were very lucky that there was a huge rise in generics then, because otherwise Part D would have been way more expensive than it's turned out to be, thanks to generics. But it sounds easy, and I think in principle you're right that the president could decide that this might be a good idea. I think he endorsed it once or twice on the campaign.
He campaigned on it, yeah.
Yeah. But when they, it's like repeal and replace or Medicare for all. It's one of those things that sounds good and polls really well, and when you actually sit down to do it, people might not like it when you have to figure out the details.
I think there's some mixed messages out of this administration on this very question. So the president did campaign saying that he thought Medicare ought to be able to negotiate for drugs. He didn't understand why they couldn't, and he thought it was, all these other countries were getting better advantage of the system than we were.
Which they are.
The President's Health and Human Services Secretary, Alex Azar, on the other hand, has come out very strongly against this idea, saying that, having a system that's not market-based is going to be terrible. And socialist, and he's used some stronger terms too. But then, weirdly, this sounds really nerdy, but this Part B demo that Paige was just talking about, so there's prescription drugs you get at the drugstore, and then there's drugs that the doctor gives you, like a chemotherapy drug or a rheumatoid arthritis drug. And basically what the Trump administration said they want to do is they're going to come up with a price that they're willing to pay for certain drugs, and that will be the price for that drug, and for half of the country that will be the price at which that drug will be purchased. Now, that sounds a whole lot to me like the kind of price setting that Alex Azar has said that he's against.
Although they already set prices for Part B drugs, although it's based on the price. But
it's not based on some number that the HHS department cooks up. It's based on some number based on what the wholesale price of the drug is in the market.
It's like the original Medicare. It's effectively based on what the
it's still the drug companies that are setting the price, basically.
All right, so turning to our bread and butter, Medicaid. I'm not going to get into an argument about whether or not there was a blue wave on Tuesday. Can we agree there was an expansion wave? Is this the trend that states who have refused to take the field say, okay, let's turn it over to the voters, since clearly once handed to the voters, we're on a roll here? I mean, what do we think about that?
Well, they
as a
could
trend?
do ballot measures in at least 6 other states, is my understanding from talking to different groups who are bringing the ballot, because all states have kind of different ballot rules and all of that. If they were to expand in places like Florida, you'd have a major expansion, but it doesn't look like that's what's happened there.
Could
there
they do it in
there were
Florida?
some areas.
Is Florida one of the states where they could?
Project told me, that
Yeah,
they
Florida's
had
one
their
of
eye
them.
on that one next. And so that is, potentially then you could see as many as 1 million more people enrolled in Medicaid. But there were some areas where Medicaid wasn't as successful. With Montana, the tobacco spending ballot did not go through. So now that kind of kicks off a battle with the state legislature as to how to fund the state's portion of the Medicaid expansion. And then there are still a lot of states that are looking at work requirements as a way to kind of, winnow away at the number of Medicaid enrollees that they have, or because of philosophical decisions that they want to make about who's on the Medicaid program and who isn't. My understanding is Alaska also might be a potential rollback of the Medicaid expansion.
Alaska and Montana, although Montana still has a Democratic governor. Alaska, the governorship changed hands. So there were two states where, obviously in Maine, where the voters passed it last year, but the Republican governor refused to implement. They now have a Democratic governor who ran on this, and they will probably implement. In Wisconsin, where they didn't actually, I'm sure you all know this, technically need to expand because they had Badger Care that went up to 100% of poverty, and over 100% you could get subsidies. But there's some talk that it might. And then Kansas, of all places, where the legislature passed it last year and the governor vetoed it, and they couldn't override the veto. Now we'll have a Democratic governor. So you're sort of seeing it go both ways.
I think Medicaid expansion was, in fact, the most important and fascinating part of the election. You had red states that went for Medicaid expansion, and for the organizers who are trying to expand Medicaid in the other states, this to them was a huge deal. And they are right now picking what states they're going to look at next. And I was speaking to them, and I was talking about Florida. And that's sort of the holy grail for the Medicaid expansion folks. And they were like, look, the election didn't go the way we wanted for Medicaid expansion, but on the ballot initiative, Florida did give felons the voting rights. So they feel like if they take this to the people, there's a real chance that this will pass. And I think, yes, it didn't pass in Montana, but keep in mind the tobacco industry spent $18 million because, was it million? Yeah, because of the fact that it was going to be funded with a cigarette tax. So that was sort of, but in the other states, you're not really seeing the groups which have been predominantly backed by the Koch brother industry, you're not really seeing them getting that kind of huge funding infusion to do the pushback. So I think that this was really going to be one of the most fascinating things to watch going forward, and potentially where some of the most fundamental changes in healthcare access could come.
And I think it comes back a little bit, Rodney, to your question earlier about how's the Affordable Care Act doing, and the ways in which Obamacare as this distinct entity is sort of becoming more nebulous. I think for a very long time there were some political actors in states that did not expand Medicaid, that didn't do it because they didn't want to accept that part of Obamacare which they were against. And there was a sort of a rejection of Obamacare, and that's why they didn't expand. I think there are other states where there was a desire not to expand because of issues having to do with fiscal capacity, or sort of just a different kind of ideology about what the role of Medicaid was and who it should serve. But I think what we're seeing is some softening of that kind of anti-Obamacare reason for not expanding Medicaid. And so, we're 2 years into the Trump administration. Obama's not president anymore. This is a policy opportunity that exists for states. They got to put up some money, but they get a lot of money. They can cover a lot of people. It can help them achieve certain public health goals that they have, particularly around opioids. I think now is salient.
And make their hospital communities really happy.
Yeah, I was going to say that's a big player.
But I think
there's
still a lot of local variation. We've seen these states now that have done this through ballot initiative. There are a couple states where the legislature is looking at it. I think to add to Julie's list, I would maybe add North Carolina as one that is talking. But so I think, and it's been this kind of slow motion rollout all along anyway. There was this big, big chunk of states that did it right away, and we kind of see in dribs and drabs other states expand. So it seems like the momentum is in the direction of continued expansion, but it probably won't go everywhere in the near future.
Work requirements. Think that might be a subject of note the next 2 years? Where do you see that going, particularly looking at it from an oversight perspective? Because the Democrats are going to control the House, and they have the ability to make people do like this. I mean, how's that going to go?
I think that's going to be one of their early targets, particularly Arkansas, which has become sort of the poster child for this isn't really about community involvement, this is really about kicking people off of Medicaid, and I think we're going to see a lot of that. I think that this has been mostly flying under the radar, I mean, not for people in this room or the people up here. We've talked about it a lot, but I don't think it's been as big an issue as something like pre-existing conditions or just the expansion of Medicaid in general, but I think it's about to become a big issue. From what we can tell, the administration is not backing down.
I think you're going to see more litigation too. I think that you've got, Arkansas and Kentucky, but I do think you're going to see some more litigation around this too.
And we're seeing oversight from other sources too. I mean, MacPac just sent I've never seen a letter like that from MacPac where they basically, told CMS like you're messing this up and you need to hit the pause button and do better program design.
Yeah, somebody was saying, oh, well, MedPAC makes recommendations all the time, and I'm like, MedPAC, I can't remember MedPAC ever sending a letter that said, that you must stop the Part B demonstration because it's hurting people.
I'm curious though to see, I mean, there is a pretty wide variation, I think, in the details of these requirements. So like Arkansas is really strict. I think you can get kicked off after just 1 month of noncompliance.
3 months.
Yeah.
But for the rest of the year.
What? Okay. And Wisconsin, though, it's much more lenient. I think it's like 4 years. And so like when I've talked to Medicaid plans, that's one of the things they've stressed to me is that the effects of this are going to widely vary depending on like what the regulations are on, how long you can go without submitting the paperwork or complying fully. As far, I mean, because if like most obviously, as we all know, most enrollees are already working. A lot of these requirements are either already being met, or there are a lot of ways to meet the requirements. But the real problem here is with people not being aware that they have to submit proof or all of this red tape. And so I'm really curious to see kind of how that plays out when you look at like the contrasting approaches these states have taken.
Also, I think the big issue is whether it expands to states that have not expanded Medicaid, which would basically, so meeting the requirements in a lot of those states would make you ineligible for Medicaid. So it really does become sort of a catch-22 that, if you earn enough to meet the community service requirements, you earn too much to get Medicaid in, I think, most non-expansion states.
But the politics of work requirements are interesting because the public really likes the idea of them. I think there's just a general, people have a sort of ethical sense that if you're going to get this benefit from the government, you should make some affirmative effort to go out there and contribute to society. And so I think that means that politicians like this idea, and if the courts don't totally squash it, I think we're going to continue. We've seen a lot of states that have made these proposals. We have an administration that has really signaled a great openness to granting them in a lot of different circumstances, and it seems reasonable to expect, that we'll see more of them, particularly maybe in some of these more red states that are looking to expand for the first time. You could see sort of trade-off, like, okay, we're going to do an expansion, but this will be the way that we'll put a more conservative stamp on it.
But drug testing, when Wisconsin didn't, so I think it's interesting to kind of see legally where kind of the lines are being drawn.
So for the people in this room who live and breathe Medicaid every day, it's important for them and how it is presented and that it's presented accurately. And you all as journalists, you have to go out and gather information. Can you sort of walk through the things that help you better do your job, and for folks in the room here, how they can communicate with you to make sure that the way they see Medicaid and the way they particularly that it is viewed by people who then read your work, that it's accurate, that it represents where they are, it represents what they're trying to do. I mean, what are the challenges that you face in making sure that we're all at least representing a objective reality here?
I mean, the most basic thing is to talk to us. I mean, we're busy and easily distracted, but also our lines are open and we care about the things that you guys care about, and we want to be able to tell the public about what's happening in Medicaid. And so if there are things that are happening that you think are important and are undercovered, or you think are being misunderstood or described inaccurately, like, we want to know that. I think sometimes, you guys out there working in the trenches feel like there's like some weird barrier between us and you, but there really isn't. We're really easy to find, and we actually want to know information. We want to share information with the public. That's sort of what we're here to do.
And I think it's important to talk to your local reporters, because they're the ones that are on the ground, and they're the ones who are more likely to cover it. And a lot of us do a lot of our research by starting with local papers and seeing, oh, well, that's what's going on. I mean, we know that Medicaid is 56 different programs, but a lot of people don't. A lot of people even think that it's 50 different programs. That Medicaid is different, and remains different in every, state, territory, and here in the District of Columbia. But I think it really helps if you can help your local reporters, fewer, I guess, local health newspaper reporters, but there are radio reporters in places, and there's even TV reporters, and you really can, it's not that hard to explain some of this stuff, and it can be really helpful, and that stuff actually does trickle up to us, although you're always welcome to call me.
I think one of the challenges for me with writing about Medicaid is, it's already the case as a health policy reporter that I'm sure for all the ladies up here, we dabble in a lot of areas. Like, so one day we might be writing about a part of Medicaid the next day reproductive rights another day. But it's even harder with Medicaid because, as Julie's pointed out, there are like a million different Medicaid programs. And, so like we write a lot about like trend stories or trying to group together states that are trying to take similar approaches. Anytime you can like reach out to us with a story along those lines or just kind of help us to understand like what makes your state's Medicaid program unique or particularly interesting to write about. But for me, that's the challenge, is just the diversity that you all represent.
So, I think having arrived at 1:15, ladies and gentlemen, Stephanie Armour, Paige Winfield Cunningham, Kimberly Leonard, Julie Rovner, Margot Sanger-Kentz. Thank you for hosting us.
All right. That's a great way to end it. I want to thank everybody. This has been a fantastic couple of days. I think this is clearly our biggest meeting ever. I think this was our best meeting ever. I want to thank all my staff. I want to thank the ARB staff. I want to thank everybody who's here who makes this possible. We'll be here again next year, and we're going to try to make it better yet than this year. Thanks, everybody.